Of course, I'm just starting in my career, and if I look at the room full of such accomplished people, I'm merely starting in my starting phase. So let's just begin with the talk. So we have all been speakers for Tirzepatide at various points, and by this moment, we have all kind of memorized the four kinds of slide decks that they have. But I promise, but I promise that this slide deck is the different one, and I have also seen it for the first time. So let's just discuss some mechanism of actions. So as we all know that we are being all sponsored by the good people of Eli Lilly, and so it's an imbalanced, as we all know that GIP agonism is 5 times more than the native one. GLP is slightly less, and this study has the objective to assess the activity at GIP and GLP. So tirzepatide is biased towards GIP if we compare it to the GLP, which is the lower one. And receptor specific beta arrestin signaling is there, which is preserved at GIP receptor while much reduced at the GLP receptor. So, if we look at the effect of tirzepatide on islet function and insulin sensitivity, the GPGT study was a multi-center randomized double-blind parallel arm phase 1 study in participants who have had diabetes for at least 6 months, and they were being treated with lifestyle interventions, stable dose metformin with or without one additional stable dose of other molecules. So we had placebo, then we had semaglutide of 1 milligram, and we had the tirzepatide starting from 2.5 and going all the way up to 15, which was the maintenance phase. And we followed up the patients after 4 weeks. The primary investigation was to investigate the effect of the molecule on the change in clamp disposition index. And the secondary objectives were glucose control, insulin secretion rate, sensitivity, and glucagon concentration. So the hyperglycemic clamp states that in semaglutide, the first phase change was 298 percentage, whereas if we look at tirzepatide 15 milligram, it was 42%. This was first phase. If we look at the second phase, the figure was 223% for sema and approx one third higher than that, 302% in tirzepatide arm. So this shows that there was significant higher excretion secretion of insulin in first phase as well as the second phase if we compare both the molecules. If we talk about the glucose infusion rate, it was much higher in cases of tirzepatide, and if we look at the insulin sensitivity M value, again it was approximately 40% higher in the patients who were on tirzepatide as compared to semaglutide. So both the slides show that how different are two molecules. Whereas if we talk about the dose, the comparison should have been 2.4 of sema with 15 of tirzepatide. So it's a bit unfair to say, but these were the results. Then if we talk about the counter-regulatory response to hypoglycemia, again, the same escalation was done, and hypoglycemic clamp procedure was done after one study period. Then, again, on the higher dose, the hypoglycemic clamp was done. This was followed up for around 12 weeks. Let's look at the results. So, change from target glucose of 100 to target nadir of 45. If we look, tirzepatide shows intact glucagon response to induced hypoglycemia in type 2 patients. So, it was not much of a significant difference between placebo and tirzepatide. It also showed weight independent insulin sensitivity compared to placebo or semaglutide. So blue line is with tirzepatide, so we get a sharp exponential curve here, whereas semaglutide it was mostly on the slightly horizontal side. So tirzepatide improves insulin sensitivity beyond the effects attributable to weight loss, indicating a weight independent metabolic effect, as Sir was commenting. It also reduced body weight compared to placebo in patients with obesity, that we have already established. This is a repeated slide that we see everywhere. It also showed change in the body composition, as my seniors commented. So 33.9% change from baseline total fat mass in tirzepatide as compared to 8.2. Same with lean mass and same with the visceral fat mass, which was the most beautifully impacted with a decline of 40% in visceral fat as compared to only 7% in placebo. Sleeping metabolic rate was also studied in this. The similar study structure, placebo and tirzepatide from 2.5 to 5, and it was followed up for around 18 weeks. This is GPGU study. Tirzepatide did not attenuate weight loss, induced reduction in sleeping metabolic rate and 24-hour sedentary EE in patient participants with obesity. So if we compare it with the baseline sleeping metabolic rate, it was significantly different from that of placebo, around more than 50% change. If we look at the delta sleeping metabolic rate, not much of a difference. 24-hour sedentary EE, that is energy expenditure, was also enhanced by almost double in tirzepatide. And if we look at the change in sedentary EE, it was almost similar. Tirzepatide decreases food cravings. We all know that. There are also reports from US and European markets coming in that people have reduced tendency to shop, reduced tendency to engage in other risk behaviors and in uh, cravings of various things like watching television, shopping, and various other things. In addition to reduction in the food cravings with the changes in the hedonic center. So food cravings were significantly lower in tirzepatide arms. The most impactful was the reduction in cravings of sweets. So tirzepatide and semaglutide increased overall appetite VAS scores, indicating reduced appetite, as we have seen in our clinical practice. So tirzepatide improves glycemic control by enhancing the secretion as well as sensitivity of insulin along with glucagon regulation. It is incretin, so it enhances glucose dependent insulin secretion, improved beta cell responsiveness, and functional capacity under the golden clamp conditions. Tirzepatide improves the sensitivity, contributes to more efficient glucose utilization, reduced insulin demand, and it modulates glucagon dynamics, supporting better suppression of inappropriate glucagon secretion and improved glycemic regulation. With this, we come to the end of the talk.